Thank you very much, Melinda, for the introduction. And indeed, it's very gratifying to see you guys face to face. In fact, I have met many of you 12 years ago at the very first patient support forum in Shangri-La Hotel. And it really attests to the fact that myeloma is right now really a chronic disease, not like a terminal cancer. And one day, I'm sure we will beat multiple myeloma. So today, I'm given a very challenging task to talk about minimal residual disease. Now I'm shifting gear a little bit to something that's a little bit more scientific. I hope you're able to follow me, and do forgive me if I go a little bit too fast. So what is minimal residual disease? You might have heard of it this as you speak to your doctors in the clinic. Well, the definition is the most minute amount of disease that you can measure with prevailing technology. So what does that mean? To understand it a little bit better, it's best to go back to Myeloma 101, and so you'll be able to grasp the concept of what MRD is. So we know that myeloma stems from a group of plasma cells that turned cancerous. Instead of producing normal antibodies that help us fight infections, these antibodies or cancer proteins known as monoclonal proteins can cause some bodily harm, can affect the kidneys. The myeloma cells themselves can cause bone fractures. And of course, many patients end up with anemia. Now, after treatment, the best way to assess if you're responding to the disease, well, the most direct way is to repeat another bone marrow biopsy. But of course, this is invasive. Some of you may experience the pain associated with bone marrow biopsy. But this is the best way for us to smear the bone marrow juice to see and count how many plasma cells are left in the bone marrow. So traditionally, if you get less than 5% plasma cells in the bone marrow, you do significantly better. Just to quickly run you through what survival curve means, because I'm going to show quite a fair bit of survival curves. So actually, it charts a cohort of patients on a certain treatment over time. And every time a patient relapses or a patient dies, the curve starts to drop. So of course, if you're comparing two cohorts, you always want to be the curve on top. The flatter it is, the better it is, because it means that fewer patients are relapsing, fewer patients are dying. An easier way to assess bone disease, to measure disease treatment efficacy, is of course doing a blood test. So right now, or urine test. So I'm sure many of you are familiar with the tests that you do every time you go to the clinic. This is the measurement of the monoclonal protein. We want to quantify if after treatment is coming down. Another way to measure the type of protein is immunofixation. And so if you get less than 5% plasma cells in the bone marrow, and you have disappearance of your M band and your immunofixation is normal, this is what we call complete response, or CR. And for the longest time, this is what we have always been aiming for. Over the past 10 years or so, we've been doing this other test called kappa lambda free light chains. This, in essence, measures a smaller fragment of the monoclonal protein. It is a little bit more sensitive. To me, it's like a loose change. You're measuring the coins instead of the dollars. And if you get a disappearance of the light chains as well, then you reach this level of complete response called stringent complete response, which is even better than the routine complete response. Now, I've covered the evolution of treatment for myeloma last year, but how does this, how does CR fit into the grand scheme of things? So over the years, we know chemotherapy was accidentally discovered after the World Wars, and for a long time, treatment of myeloma with chemotherapeutic drugs, steroids, were mainly for palliation, to prevent pain and also to prevent patients from ending up like Sarah Newsbury, the first myeloma patient ever described, with very bad contorted bones because of many fractures. So complete responses then was just a rarity. Hardly any patients attained complete response. But later on, we started developing, we started doing autologous stem cell transplant so as to allow patients to receive a very high dose of chemotherapy drug called melphalan. With autologous stem cell transplant, about 30% of patients can attain complete response. But again, Melissa would agree with me, this is a very ageist approach. It's very discriminatory against older patients who are afflicted with multiple myeloma. Just because they cannot do a stem cell transplant, they could not smell a complete response. So for physicians, we really don't like to always use the term transplant eligible, transplant ineligible. Overall, we want to treat all patients just the same. So things are changing. Eventually, we could do without the term transplant eligible or transplant ineligible. So in the 2000s, new drugs were introduced. Of course, you are familiar with bortezomib, thalidomide, lenalidomide, and the second generation carfilzomib and pomalidomide. With these drugs, even without stem cell transplant, we realized that, hey, we could actually induce a complete response in about 30% of patients. Traditionally, we only thought that only a stem cell transplant could bring you there. And if you use these drugs up front and then you go on to a transplant, about 50% of patients can attain complete response. Why is complete response so important? Is because if I can attain a deeper response, then it takes a longer time for these remaining cancer cells to regroup and re-emerge and dictate a relapse. So in essence, you're actually buying this extra time if you are able to reach a deeper level of remission. So we were aiming for a deep remission. Complete response was what we were aiming for. Now, overall, if you look at natural history of multiple myeloma, generally we say that myeloma is not curable. So with the first treatment, we bring patients to a plateau remission. So complete response represents the best plateau remission one can get. And unfortunately, most patients will relapse subsequently. We treat again, patients may relapse again, we treat again. So in essence, patients may have many different remission durations, but typically the best bet or the best return on investment is usually the first treatment, because this is when the disease is treatment naive and very sensitive to any therapy that you throw at the disease. The first remission is typically the longest as well. Now, while for a long time we were resting on our laurels of attaining a CR, but then we realized that we were duped into believing so, because CR is just the tip of the iceberg. If you can assume that the tumor burden, disease burden in the body is represented by an iceberg, then with the current technologies that I've alluded to earlier on, the bone marrow smear, M-band, immunofixation, light chains, we're actually measuring just the iceberg that is above the water surface. There's a lot more disease that is hidden, and this is what we call minimal residual disease, the disease that is not measurable with these routine tests that we have been doing. CR only brings you to this level, the level of the surface of the water. So with better technologies, you dive deeper, you can ascertain if you indeed getting rid of the rest of the iceberg. You need better technologies. And so what are these technologies to help us measure minimal residual disease? Perhaps if you can get to the bottom of the sea, this is where you could find the holy grail of cure for multiple myeloma. We're getting excited because now with technology, we're able to measure this bit of disease that is left in the body. So currently, the two available technologies that help us measure the the most minute amount of disease in the bone marrow are next generation flow cytometry and next generation sequencing. So in Singapore, next generation flow cytometry is available when you go for bone marrow biopsy. Next generation sequencing is still not available on a commercial basis. So these tests are able to help us determine if you have one cancer cell in 20 million cancer cells in the bone marrow, so it's that sensitive. And also right now, we're beginning to appreciate that as myeloma patients are living longer and longer, sometimes the cancer cells are not just hiding in the bone marrow, they can be hiding elsewhere in your body. So just to ascertain that you're really getting rid of the minimal residual disease, we also want to make sure that there's no myeloma cells hidden elsewhere in your body. That's why we order a PET scan, just to make sure that we don't see any signals coming from anywhere outside the bone marrow compartment. Now, this is one of many curves of studies that have shown that if you are able to attain minimal residual disease negativity, then you're all the way up here. So this is looking at patients who were treated with Velcade, lenalidomide, and going for transplant. At about 5 years, majority of them are still in remission if they are able to attain MRD negativity. Unlike patients who were CR but MRD positive, conventionally, previously, we were always gunning for the CR. We now realize that if you are in a complete remission, but yet you're MRD positive, you are right at the bottom here. So So our treatment goals have actually changed of late, because we know that if you get CR, you get MRD negativity, you're like at a safe haven where you'll be disease-free for quite a long time to come. This is regardless of whether you attain CR by the transplant route or without transplant. So long as you attain MRD negativity, you do significantly better compared to the counterparts who are MRD positive. But of course, if you go by the transplant route, the proportion of patients attaining MRD negativity will be significantly higher. Now, what is really important with the ability to detect MRD is amongst patients with high-risk genetics. So you must have heard that some patients have very bad mutations like deletion 17p414 translocations. These patients are the ones that we still consider having a disease that is still akin to a terminal cancer, and we want to do what we can to really save these patients from succumbing to multiple myeloma. These patients, after treatment, if they are still MRD positive, they don't do very well, and typically we're looking at survival of about 3 years, 4 years. But now, patients with high-risk disease, they have a reprieve. If they're able to attain MRD negativity with whatever means in the frontline setting, then their destiny is like reset, and their outcomes could be just as good as the counterparts without the high-risk mutations. So right now, we are really focusing a lot of attention on patients with bad risk disease, because we really want to give them a chance to lead a normal myeloma life and not succumb to the disease very early in after diagnosis. So what is the hype about this MRD, and why are we trying to evaluate MRD status for patients with myeloma? Is what Dr. Molly has alluded to. Right now, with the introduction of immunotherapy, there are various forms. Of course, everyone is familiar with daratumumab, which is the simplest form of immunotherapy using monoclonal antibodies. MRD is very common. Many patients attain MRD negativity with new tools, new drugs in our armamentarium to tackle myeloma. Many patients are attaining MRD negativity, and so we think that this is the best way for us to measure disease response with these new techniques to treat multiple myeloma. But the best way to really appreciate how far we've come is actually to look at patients who are transplant ineligible, those patients who never receive a transplant. And if you look at the treatments that they receive since the 1980s, in the early years, melphalan, prednisolone, these are like very primitive medications. Then we added thalidomide that comes with a lot of side effects, especially nerve injuries. We added Velcade, then lenalidomide, represented by R, which is the original name, Revlimid. And over the past few years, we added daratumumab to the frontline setting, to Velcade or to lenalidomide. You can see that the CR rates went up from 4% to almost 40 to 50% with the addition of immunotherapy to the frontline setting. And also the remission duration becomes longer and longer after the first line treatment. Previously, we were looking at like 1 year, 2 years, and right now with the strongest regimen, or most effective regimen for patients who are not going for transplant, which is DRD, daratumumab, Revlimid, dexamethasone, you're looking at a remission duration of about 5 years. This is what you could expect with a stem cell transplant. Now these patients are not going for stem cell transplant. And most impressively, MRD negativity is a reality. Previously, we never expect patients not going for transplant to even be MRD negative, but right now, a third of these patients receiving daratumumab upfront can be MRD negative. Now, if you look at patients who are transplant eligible, of course, the outcomes will even be better. Right now, the standard of treatment is VRD, Velcade, lenalidomide, dexamethasone, followed by autologous stem cell transplant. But researchers are getting a little bit more innovative. We have started adding daratumumab to the backbone of bortezomib, thalidomide, dexa, or bortezomib, lenalidomide, dexa. These are two very important studies called the Cassiopeia study and Griffin study. There are also researchers in Europe that who are adding carfilzomib, which is a second-generation proteasome inhibitor, which is more potent than bortezomib upfront. And there are now studies looking at just patients with high-risk disease. This is what we call the kitchen sink approach. You throw in the best medications upfront. hoping that you can change the natural history of myeloma for these patients with high-risk disease. And there's also a study that throws in all these most powerful medications, and if these patients attain MRD negativity on 2 consecutive occasions, you stop the treatment. So this is something very provocative and controversial, because in myeloma, we always do not think of stopping medication for patients. Now we are heading this direction because we're able to measure MRD, and we have the very, very potent medications to control the disease. Now, if you look at MRD negativity for these treatments, you'll see that I've not even listed CR, because you expect CR in the majority of these patients who go for transplant. But when you're looking at MRD negativity, this is with daratumumab upfront, 60-70% MRD negativity, and with the kitchen sink approach, 80% become MRD negative. So this is something that we previously have never, this kind of progress we've never seen previously. And this is the master study which I showed for patients with no high-risk disease. If they do not have a lot of bad genetic mutations or abnormalities, even after stopping treatment because they attain MRD negativity on 2 occasions, they still remain in remission after about 2 to 3 years. So there is a possibility that one day we could actually stop treatment if you are MRD negative, if you do not have bad mutations. So while we celebrate medical advancement depicted by the ability for us to really bring the disease burden down and getting more patients into MRD negativity, but of course this comes at a price. With these drugs, of course, it's no-brainer that the latest drugs will always be more expensive, especially these innovative immunotherapeutic approaches. And a lot of the cost price of these drugs have to take into account the research that has been that has gone into developing these drugs. But the saving grace right now is that many of these older drugs, like lenalidomide, bortezomib, we are now able to get the generic versions of this, so that this in a way could defray the expensive bill size when we want to add daratumumab, for instance, in the frontline setting. Now, stranger things are happening in Singapore. Come September or maybe April, as physicians, we are only allowed to prescribe drugs for myeloma patients based on this template. So this is the final one that's going to roll out in September. So for physicians, we really feel that our hands are tied. We want to do the best for a patient. If you have high-risk disease, obviously I need to do more beyond this. So unfortunately, this is what we have to abide by if you do not have a rider, if you do not have an independent insurance, if you are pegged onto IP, this will take effect in April next year. So if you're looking at patients in the frontline setting, if you want to go with a MRD-directed or targeted approach when you're newly diagnosed with multiple myeloma, if patient is transplant eligible, I can only give you daratumumab, bortezomib, thalidomide, not lenalidomide, and dexamethasone. And for patients who are transplant ineligible, it's daratumumab, lenalidomide, and dexa. This is a very good regimen. But the caveat is that there is no government subsidy or no MAF. As physicians, I'm sure Melissa has reassured that we are finding the ways to perhaps tap into other funds to bring drug subsidy to these patients. But if we're looking at the MRD-directed approach upfront, adding a very important drug, immunotherapy upfront, is indeed very important for our patients. While I was mentioning that we are celebrating advances in the way we are able to treat multiple myeloma, our prescription pattern is going a little bit backwards, especially for patients with high-risk disease. Right now, I'm unable to give drugs like carfilzomib, which may have an impact for some of these patients with very bad risk disease. And we know that for transplant-eligible patients, we have to stick with Dara VTD if we were to add daratumumab upfront. So there are going to be many issues, many controversial issues that we have to grapple with, we have to deal with. As Molly has rightly said, patient advocacy is very, very important, because as a patient body, you have the loudest voice. If any policy is not in the best interest for a patient, patients actually have the loudest voice to engage stakeholders, engage MOH, engage ACE, to tell them that you want to have better options for the treatment of multiple myeloma. Of course, the grand scheme of things is that this is for cost containment, and some of these expensive regimen is not cost effective. Now, what is cost effectiveness? Is it to stinge on the first line treatment and have to spend a lot of money for more expensive treatment like CAR T cell therapy, which costs like $500,000? Is this cost effectiveness? To me, my preferred model is to invest heavily in the first treatment, because this is where the disease is most sensitive, bring the disease down, aim for MRD negativity. For some patients, MRD negativity can be sustained, and only time will tell if some of these patients could indeed be cured. So, I mean, it's hypothesized that if you are MRD negative, like for 5 years consecutively, perhaps some of these patients could actually be cured. But at the very least, we know that MRD negativity that is sustained is the prerequisite to curing myeloma. But majority of patients, despite being MRD negative, could still relapse. But we want the first remission to be as long as possible so that most patients can lead a normal life and not be too bothered by multiple myeloma. So what is the role of MRD testing now? It is still not prime time for us to do it on a routine basis. Suffice to say, right now, there are many international trials looking at inserting MRD assessment at different time points of myeloma treatment. So in this way, we want to be able to be better informed if MRD status will help us determine if we should stop treatment, de-escalate treatment, or intensify treatment if a patient does not attain MRD negativity. In the very near future, MRD-guided or response-adapted treatment is the way to go for multiple myeloma. So to conclude, MRD is now the most sensitive assessment of treatment efficacy. It is the best prognostic tool for multiple myeloma. MRD is the treatment goal for most patients, regardless of transplant status. However, patients may still relapse if they are MRD negative, but only time will tell if some patients with sustained MRD negativity can be cured, and certainly this is the prerequisite to curing multiple myeloma. Currently, this is being evaluated as a tool to tailor treatment. The key to improved survival outcomes is to sustain access to novel therapeutics that target the MRD. And this is very important. Engaging various stakeholders is the key to finding solutions for affordability and access to new drugs. In multiple myeloma, it's all about accessing these latest drugs to defy the natural history of the disease. And it doesn't just come from the doctor's prescription, because as Molly has mentioned, myeloma drugs are getting more and more expensive. We need to figure how we can bring these drugs to most patients or all patients with multiple myeloma, and we really need to engage the pharmaceutical companies, the government, MOH. So I thank you for your kind attention, and I'll be very happy to take more questions later when we have the panel discussion. Thank you very much.